Crohn's by Myrtle Pettit. Today we'll tackle Crohn's disease in a particular case study. But to get an overview of the disease, let's watch a short video clip about Crohn's from Mechanisms in Medicine.
What is Crohn's disease? Crohn's disease is a chronic condition characterized by inflammation in the gastrointestinal or GI tract, which is also known as the digestive tract. Since Crohn's disease is a chronic illness, it is persistent and will be present throughout a patient's life. However, patients and physicians can work together to manage the symptoms of this disease. The GI tract includes the mouth, esophagus, stomach, small intestine, large intestine, and anal region. Crohn's disease can affect any part of the GI tract, but the most common location is the last part of the small intestine, which is called the ileum, and the first portion of the colon, which is also referred to as the large intestine. Current thinking is that Crohn's disease is a genetic disease caused by abnormal regulation of the immune system. The GI tract is frequently confronted with bacteria from our diet and environment. Many factors can contribute to a person's risk of having Crohn's disease, but most can be thought of in three categories: genetic predisposition, environmental factors, and a dysregulated immune response in the GI tract, which causes inflammation. Environmental factors that may contribute to Crohn's disease include infections, smoking, and taking antibiotics or anti-inflammatory drugs known as nonsteroidal anti-inflammatory drugs, or NSAIDs. One way that the body can protect against potential bacterial threats is with inflammation. We are familiar with how inflammation looks on the outside of the body, for example, when you have a scrape or a cut. That scrape or cut becomes red and inflamed as a result of the immune system trying to get rid of any bacteria and viruses that are in the wound. After a few days, when the immune system has finished its job, it turns off, so the redness and inflammation disappear. In Crohn's disease, inflammation, ulcers, appear within the GI tract, and the immune system works to combat the bacteria and viruses in the same way as with a cut on the surface of the skin. However, the difference is that the immune system is not able to turn itself off after it has gotten rid of the bacteria or virus, so the ulcers remain until they are treated with medicine or surgery. This chronic inflammation is what causes the symptoms of Crohn's disease. The symptoms of Crohn's disease vary depending on where the disease is located and its severity. This means that every patient with Crohn's disease experiences the disease differently. Most patients with Crohn's disease have abdominal pain and diarrhea. Other symptoms related to the GI tract can include abdominal tenderness, loss of appetite, weight loss, fever, fatigue, rectal bleeding, anal skin tags, and ulcers. In children, Crohn's disease may result in stunted growth and a failure to thrive, even if GI symptoms are not present. In addition to symptoms involving the GI tract, Crohn's disease can affect other parts of the body. Symptoms outside of the GI tract can include joint pain, liver inflammation, osteoporosis, skin problems, eye problems, mouth ulcers, and anemia. Patients with Crohn's disease should expect to lead normal lives in consultation with their healthcare providers. The goal of the healthcare provider is to help people manage Crohn's disease, rather than having the disease manage them.
Let's take a look at the history of the case from Van Mitte and Hubert. Mr. PT, age 19, has had Crohn's disease, affecting the ileum and part of the jejunum, and for 5 years has had numerous exacerbations. Several members of his family have a history of Crohn's disease. He has delayed growth compared to his peers. Later on, he developed fistula between the ileum and the bladder and is at risk for intestinal obstruction. Now let's take a look at the pathophysiology of Crohn's disease. Etiology is unknown. Through GI series, it is observable to see scattered inflamed patches in the GI tract. There's also cobblestone appearance in the gut lining, as you can see on the picture. A portion or even an entire GI tract can be affected. So what are the risk factors? Age, 15 to 30, as some literature says. Other literature says 20 to 30. Our patient PT is 19 years old. Although the ethnicity is not indicated, the ones that are most commonly affected are Caucasians and Jewish people. Family history has high risk in which the patient also has a family history of Crohn's. Cigarette smoking is a precipitating factor, and NSAIDs a predisposing factor. So here are the signs and symptoms. Diarrhea is very common. Fatigue, fever, loss of appetite, and weight loss. Abdominal pain, tenderness, and cramping. PT experienced numerous exacerbations for the past 5 years. What are the common exacerbations? Nausea and vomiting, which are noted because it involves the stomach and the duodenum. Pneumaturia, air is found in the urine. Dysuria, a burning pain sensation while urinating. Recurrent UTIs. Urourea, involuntary passage of urine. Fecaluria, fecal matter passes in the urine, which shows that the integrity of the bladder is compromised. Hematuria, blood in urine. And hematochezia, blood in stools. And the patient suffers from macronutrient deficiencies, micronutrient deficiencies, as well as anemia, and even vitamin B12 deficiency. This is due to the malabsorption and the malnutrition because the gut lining is compromised. And this is very true with our patient PT who suffered from delayed growth and his height is shorter than his peers. Nutritional deficit or deficiency is largely a contributing factor to the patient's stunted growth, especially if he has Crohn's as a child. What are the common complications? Bowel obstruction, fistulas, malnutrition, anemia, mouth ulcers, liver inflammation, skin problems, eye problems, osteoporosis, and even sepsis. So there are several laboratory tests that could be done. Antibody tests, such as anti-Saccharomyces cerevisiae antibody test, ASCA, and parenchylar anti-neutrophil cytoplasmic antibody test, or PANCA, CBC, complete blood count, C-reactive protein, electrolyte panel, erythrocyte sedimentation rate, iron and B12 levels, liver function tests such as AST and ALT. So quickly, let's revisit Crohn's disease again to review and gain a deeper insight about this disease through a short video from Alila Medical Media. Just a disclaimer, I do not have a copyright of the said video. This is just for educational purposes only.
Crohn's disease is one of the two major forms of inflammatory bowel disease. Inflammation caused by Crohn's disease may affect any parts of the gastrointestinal tract, but it most commonly involves the end of the small bowel, the ileum, and the beginning of the colon. The inflammation is not continuous. Inflamed segments are usually interrupted by normal, healthy tissues. Most people experience recurrent flares when the disease is active, followed by symptom-free periods of remission. Symptoms may differ depending on the parts of the digestive tract that are affected. Most common signs include diarrhea, abdominal pain and tenderness, loss of appetite, weight loss, fatigue, and fever. Blood in stools occurs when the colon is involved. Nausea and vomiting are usually the signs that the stomach or the first part of the small intestine is affected. About 1/3 of patients present with perianal disease, including abscess, fistulas, and ulcers. The disease also often manifests outside the intestine, especially in the joints, skin, and eyes. Inflammation in Crohn's disease extends to the entire thickness of the intestinal wall. Deep lesions in the mucosa often alternate with areas of mucosal swelling, creating a characteristic cobblestone appearance. Extensive inflammation may cause thickening of the bowel wall and hypertrophy of the mesenteric fat that wraps around the intestine. Intestinal wall thickening, together with scar formation, may block the flow of digestive content, leading to bowel obstruction. Ulcers can extend through the bowel wall and form tunnels called fistulas, which may connect to other loops of the intestine, to abdominal organs, muscles, and even skin. A fistula may become infected and form abscesses, which can be life-threatening if not treated. In the long term, Crohn's disease may increase risks for colon cancers. The disease has a major peak of onset between the age of 20 and 30, and a smaller peak later in life. White individuals, people with family history, and smokers are at higher risks. The exact mechanism of Crohn's disease is not fully understood, but it likely involves both genetic and environmental factors. Multiple genes are identified, most of which act in the immune system, or in maintaining the gastrointestinal epithelial barrier. This barrier separates the gut content from the underlying immune system, preventing the body from reacting to dietary antigens and resident bacteria of the gut. A crack in the barrier may increase the chance that the immune system overreacts to non-pathogenic antigens from the gut content. Involvement of environmental factors is evidenced by higher disease incidence in developed countries, especially urban areas. Diagnosis is made based on a combination of tests and imaging procedures. Treatments start with dietary management to maintain good nutrition but avoid foods that may exacerbate symptoms. Some patients may benefit from nutrition therapy, a special diet given via a feeding tube or injected into a vein. The therapy provides nutrition while allowing the bowel to rest, reducing inflammation. A number of medications can be prescribed depending on disease severity and the patient's response to different drugs. These may include antidiarrheals, anti-inflammatories, antibiotics, corticosteroids, immunomodulators, and biologics. Abscesses and fistulas are drained and treated with antibiotics. Nearly half of patients require at least one surgery to manage recurrent intestinal obstructions or complicated fistulas or abscesses. Surgical removal of the diseased parts of the bowel may improve symptoms temporarily, but is not a cure because the disease is likely to recur, usually near the reconnected tissue.
With Petey's case of Crohn's disease affecting the jejunum and the ileum, and later on developing a fistula between the ileum and the bladder, as it is in close proximity to each other, the diagnosis is jejunoileitis, Crohn's disease with enterovesical fistula. Let's take it apart and explain one by one. Jejunoileitis. The area affected in this type of Crohn's disease is the jejunum and the ileum, which is both inflamed. There are other types of Crohn's depending on the location, but we'll not cover it in this presentation. Let's move on to enterovesical fistula, also known as enterourinary fistula, EUF. Fistula occurring in the ileum or close to the terminal ileum reaching to the bladder, which is in its close proximity wherein the integrity of the bladder dome is affected. How is the fistula formed? First, there's serosal cohesion from healthy bowel to the diseased segment. Then gradual internal perforation ensues, followed by penetration of ulcer through the newly formed wall, and finally, the development of a fistula. To visualize that clearly, I took some X-ray and CT scan images to show it to you. Here in this slide, you can see on the left upper corner the bladder and the adjacent ileum. On the CT scan on the right, you can see on the arrow a left perivesical abscess secondary to CD. And the lower CT scan shows the fistula formed between the bladder and the proximal terminal ileum. Here's another picture. An artist illustrated a better photo to show the fistula on a sagittal or longitudinal plane. The site of the fistula is enlarged, showing the connection between the terminal ileum to the bladder. Here's a list of imaging studies to diagnose and monitor this condition. X-ray, small bowel series, sigmoidoscopy, colonoscopy, laparotomy, barium enema, cytoscopy, retrograde cystography, CT scan, and MRI. Common medical treatment for Crohn's are as follows. 5-ASA compounds, also known as mesalazine, steroids, antibiotics, particularly cyclosporin, infliximab or Remicade, immunosuppressant drug such as azathioprine and 6-MP. There's also the use of parenteral nutrition for severe and unmanageable cases. So bowel rest is very important. Surgical intervention such as en-bloc resection. There are also other types of resection not indicated here. Nutritional management. Stay away from high fiber, difficult to digest foods such as fatty, spicy, dairy, and allergenic foods. Eat foods that are cooked, foods with low fiber and high protein content. Keep yourself hydrated. Water is a good lubricant and it lines the gut effectively. So drink 30 minutes before meal and 2 hours after meal. In addition, I would like to add the functional medicine treatment. This is an exhaustive list as each case is different. Functional medicine practitioners have used most of these recommendations in their practice to help patients not only with Crohn's but other types of dysbiosis. Let me start with gluten-free diet, dairy-free diet, pesticide-free and non-GMO food, Megaspore Biotic 2 caps per day, Probiophage DF 1 cap per day, Restore 1 teaspoon 3 times a day before or with meals, betaine hydrochloric acid 1 cap per day, Digest Zymes 1 cap per day, Nature's Life bromelain and papain 250 milligrams per day, GI Microbe X 1 cap per day on empty stomach, oil of oregano 1 soft gel per day, curcumin with piperine for better absorption, Paractin 150 to 250 milligrams, high potency multivitamin, vitamin B12 IM 1000 to 3000 microgram, vitamin C 1 to 2 grams or 1000 to 2000 milligrams per day, vitamin A 5000 IU per day, vitamin B complex 50 to 100 milligrams per day, flaxseed oil 1 tablespoon per day, other helpful herbs and food, slippery elm, aloe vera, carob, ripe bananas, apples, and other high pectin fruits, fennel, onion, and garlic. So I hope you enjoyed this short presentation. However, let me end with the 2 questions. Question number 1. Explain the enterovesical fistula formation and its complications. Question number 2. What functional medicine treatment is most suitable for Crohn's and why? Thank you so much for listening. I hope it is a time well spent.